either BRCA, HRR or HRD gene panel. So, in this era of precision oncology, we have introduced our brand of olaparib for the right patient, right treatment at a right price. And Ibaira plus 1 year olaparib medication. But when it comes to genetic testing, we have taken a landmark step by improving the access of BRCA and HRR gene panel, where we are offering or helping the patient with BRCA germline at less than 5,800 rupees. And when it comes to yearly therapy cost of EBI excipient, but did not find any improvement of bioavailability of olaparib. Then after they launch or they develop capsule formulation, capsule found superior bioavailability than the tablet, but they found a many issue like leakage, stability, and interaction. After that, innovator developed micronized API formulation of olaparib and developed a tablet. But micronized formulation also failed to improve the bioavailability as per the patent by the innovator and European Medical Agency report. And finally, innovator developed hot melt extrusion technology to manufacture olaparib, and they converted olaparib API into amorphous solid dispersion and developed olaparib tablet currently in India and the world. Whatever olaparib available by the innovator has been manufactured by hot melt extrusion technology. And these are the few snapshot of the patent and few publications available in the Google. So selection of a right olaparib is very, very important when it comes to generic version of PARP inhibitor. And we are the one company, or might be we are the only company in India that are manufacturing generic olaparib by using hot melt extrusion technology. So this was a small journey, and this is the Zydus commitment to the clinicians and the patient to provide Ibaira at a right patient, offering companion with companion diagnostic test. This is a Zydus commitment to the patient and the clinicians to help the right treatment, olaparib manufactured as per the innovator standard, and right price where we are most offering competitive price to all the generic version of olaparib. So this was the small journey of our olaparib, and now it's my pleasure to invite Dr. Bhavna Parikh ma'am. I should shy away by introducing ma'am because everyone who has joined this meeting know ma'am. Ma'am is a national and international faculty. Ma'am is a MBBS. Ma'am has done DNB in surgical oncology. Ma'am is currently associated with Anamai Cancer Hospital, Ahmedabad. She is having many publications under her name in various national and international journals. And ma'am is trained in breast oncology surgery, pelvis cancer surgery, GI and head and neck cancer surgery. So with this, I invite Dr. Bhavna ma'am for further discussion. Over to you, ma'am.
Thank you, Shivam bhai. Ketan bhai, can you mute other people because there is a lot of noise in between? And thank you for making olaparib available at 5,000 rupees cost, which was actually 95,000 rupees, I think last year only. And many of my patients could not afford because of the cost issue. I'm not at all an international person, I'm just a local person. But love to organize webinar and part to be an academic activity, that's it. So I'll start with the introduction. Can I share my screen, please? Ketan bhai?
Yes, please, ma'am. Yes, ma'am.
Okay, my screen is visible.
No, ma'am. If you can share again.
No, I'll just. Okay, I need to share it from. Okay. Now is it visible? No.
Yes, ma'am. It's visible now.
Okay, but I can't see this whole screen. Wait a minute. I have to change this. Mr. Speaker, open a YouTube, anything on a Google. You see, you just type a Sahu. You will see all his presentation, moderation, panel discussion, and lot of things. He did his DM Medical Oncology from Silver Line Hospital, Bhopal. He's working currently. He is a DM Medical Oncologist currently working at Silver Line Hospital, Bhopal. He finished his DM Oncology from Kidwai Memorial Institute of Oncology, MBBS and MD Medicine from SCB Medical College, Cuttack. He has more than 25 years of experience. Started his work from Indraprasth Apollo, New Delhi, to Jawaharlal Nehru Cancer Hospital and Research Center at Bhopal. He was the head and director of Department of Cancer Center at Chirayu Medical College and Hospital. He was a director and medical oncologist. He's currently a director and medical oncologist at Silverline Hospital, Bhopal. He's editorial board in India Breast Cancer Resource. He's board member of Indian Journal of Cancer Research, Statistics and Treatment, Indian Journal of Medical and Pediatric Oncology, and Southeast Journal. There's many publications. I got it from the Google. I cannot read each and every because it takes another 15 to 20 minutes of time, but you can make out the amount of a publication he has in all the subjects of oncology. I mean, all different organs of oncology. And he is principal investigator in 39 multinational multicentric studies. Today we have moderator who himself is from Ahmedabad. He is also one of the team member from our Annamaya Cancer Hospital. He's a medical oncologist for our team also, our hospital team also. He's a founder of OncoWell.
Be looking into what is happening. These are two things. And second, I will be definitely touching on two important trials on the cervical cancer, that's on the concurrent chemoradiotherapy, which will be path changing, and the way we treat cancers in 2024, at least cervical cancer, is going to change. With that, I now go on to my slides. Okay. So this is a beautiful trial which was put up in ASCO and actually was put up in a full paper in NEGM as recently as 1 to 1.5 months back. This was a simple versus radical hysterectomy in women with low risk cervical cancer. And this is something all of us have to remember, that we have been always telling our ladies or our surgeons to go for a radical hysterectomy. And this trial looked at patient profile which were considered low risk, and as per their low risk, they wanted to look into trials, to look into the patients of stage 1A2 and 1B1. And these patients were taken up and randomized, provided they were considered radiologically not having lymph node enlargement, and these patients should have an MRI done at least to show that the stromal invasion was less than half of the total stroma of the cervix. And in this patient, they were randomized to two arms, and the first arm was what we do as a radical hysterectomy, and the second arm was simple hysterectomy. And the definition of how they operated is very much there in the full scale paper. Basically, they looked at where to parametrium should not be totally resected, or parametrium should be resected to what extent. But all said and done, that simple hysterectomy was not just simple hysterectomy. They also had to do lymph node dissection. You mind it, the amount of surgery for the cervix, cervical part of the uterus did change, but there was also nodal dissection in the simple hysterectomy. That's something people have to remember. It cannot be just a simple hysterectomy as such. Point number two, this was 700 patient trial randomized. As I told you, it was 1A2 and 1B1. These were the two patients. The majority were 1B1. So by 1B1, we meant that the invasive carcinoma was more than 5 millimeter of depth of the stromal invasion, and it was at least less than equal to 2 centimeter in the diameter of the tumor. So this is what the patient profile was. So what happened actually, and very interestingly, this was a non-inferiority trial, and it showed that if you do a simple hysterectomy with a lymph node dissection in the rightfully selected patient group, it was equal in terms of pelvic recurrence at 3 years, and which was comparable to radical hysterectomy, and the primary endpoint was pelvic recurrence. What is the criticism of this? Should we be doing it in an Indian scenario? I'll come to in a minute. But the most important thing is, if you look into what happened, is the number of positive nodes were very low in both arms. The radical hysterectomy was simple hysterectomy. We look into it, was around 3 to 4%. So this was taken up in this low subgroup of patients which were actually potentially not to have the lymph node positivity, and only 4% of patients had a disease which was, the lesion size was beyond 2 centimeter, although radiologically it was below 2 centimeter, but the patch size ultimately turned out to be more than 2 centimeter, only in a minority of 4%. In the radical hysterectomy, there was only 2% patients who had a parametrium involvement, while in simple hysterectomy, none had. Again, that was the important thing is we did see the recurrence in the pelvis where it was significantly non-inferior to the radical hysterectomy or the simple hysterectomy, and the patient quality of life and the complications and the urinary disturbances were lesser in the simple hysterectomy. So tomorrow, should we be doing it is one question, and this trial did allow sentinel lymph node sampling. The point here is you should have someone who should have a very early disease or low risk as defined in the trial. The patient should have clinically and radiologically, the patient should not have any lymph node enlargement. The third, you should have a good MRI of the cervix, which was to be done on a cervical protocol, and the radiologist has to be good enough to tell you that the invasion is less than half of the cervical stroma. With these criteria, and if they fit into the stages as described as 1A2 and 1B1, I think we should start offering our patients this thing. But important, mind you, it's a very short follow-up of 3 years. There is still skepticism among the gynaec oncologist fraternity whether we should be offering this. But at least if you see the trial, it's a well-balanced trial. And this patient, the gynaec oncologist who feel comfortable, I think people will start to change. I think in after 2 years when the long-term follow-up comes in for the SHAPE trial, things are going to change. The second point which I wanted to tell very clearly is there's always a controversy of minimally invasive versus abdominal radical hysterectomy. And this trial did allow both the things. And if you look at it, it's a trial. I wanted to put things in context. Should one operate by the open way or the minimally invasive? This NEGM paper did show in this early cervical cancer group, open surgery was superior to minimal invasive surgery in terms of local recurrence, in terms of OS. So with that, I will just skip and go to the main focus of my talk, which is the MEDONC department and the MEDONC part of it. How do we need to change our cervical cancer treatment 2024? But I just felt that the SHAPE trial of a simple hysterectomy versus radical hysterectomy did worth a mention in this symposium, because there would be many who would like to know, is radical hysterectomy the way to go forward, or can we do something as an alternative? After the talk is over, I love to listen to our surgical oncologist colleagues. Are they convinced of this data? So let's come down to concurrent chemoradiotherapy. We have been traditionally doing concurrent chemoradiotherapy to patients who have been node positive or who have been more than 4 centimeters of size or who have a parametrium involvement. This is the traditional approach to what has been happening. Patients with 1A1, 1A2, 1B1 and some stage 2A are offered surgical radical hysterectomy upfront, but the rest non-metastatic are concurrent chemoradiotherapy. What have we achieved in this? In last 5 years PFS, we have achieved around 60% of the 5 years PFS with concurrent chemoradiotherapy. This is the best we have achieved in last 2 to 3 decades. Could we do more? Could we achieve more to the 60% of 5-year PFS? And is it the adjuvant way or the new adjuvant, or should we do something to the concurrent chemoradiotherapy arm and then follow it up as a maintenance? So these are the 3 approaches that can be done. So I will tell you what has changed in 2023. The first thing that has happened is the Interlace. Interlace is a trial which has a good follow-up of 5 years and more. It is an induction chemotherapy followed by concurrent chemoradiotherapy versus concurrent chemoradiotherapy alone. That has been what has been the standard of care. And this is being done, and the endpoint which has been looked at is PFS and OS. These are the co-primary endpoints which we are looking at. The secondary endpoint could be the safety, the quality of life, and the time to the relapse, and the patterns of relapse. And if you look at it, it included 1B1, but the stage 1B1 had to be node positive. So that's something people have to remember. What was the inclusion criteria?
Hello.
And 1B2, stage 2 and stage 3B and 4A could be there without any lymph node enlargement. So mind you, 1B1 was only to be included if they were node positive. And the 1B2, 2, 3B and 4A could be included and 2A was taken out because it was considered, all of us agree that 2A is majorly a surgical patient. They could be either squamous, adenosquamous, or having a mixed histology of it could be squamous, adeno or adenosquamous, and there should be no nodes above the aortic bifurcation on imaging. The patient should not have any previous pelvic artery. And the N size was 500. Again, a very robust 500 patient data. The primary endpoints and others I have already taken into. What is the protocol? For the induction chemotherapy, they used weekly paclitaxel 80 milligram per meter square along with carboplatin AUC2 for 6 weeks. So we had a 6 weekly chemotherapy with paclitaxel and carboplatin, which all of us do. And within a week of the last chemotherapy, if the counts have recovered, the patient was taken for a concurrent chemoradiotherapy, and there the weekly was weekly cisplatin at 40 milligram per meter square for 5 weeks, mind you. And then brachytherapy was given as it is, so that you reach a dose of at least 78 gray to the pointing. So this is, I'm very clear on the standard things. So let us see what happens. Look at the demographics. Very interestingly, just look at the disease characteristic on the right hand side of it. It was majorly a trial done in UK and Mexico. India did contribute to a minority of 1% of patients, 2% of patients. But look at these characteristic. What really stands out is 1B1 and 1B2 were very, very minor. The majority of the patients were stage 2B FIGO staging. Even stage 3B and 4A was very, very less. The non-squamous and squamous, it predominantly was squamous, and the nodal positivity was there in 40% of patients, 60% were node negative. That is something I wanted people to remember. And if you look at the induction chemotherapy arm, this protocol somehow was more biased towards that the more of the patients who had positive lymph nodes were in the induction arm. If you look at the concurrent chemoradiotherapy arm, only 40% were node positive. If you look at the induction chemotherapy arm, 80% were node positive. So this is what we're looking at. One more classical thing that happened is important is the type of technique that was used. IMRT was not used in majority of patients. And if you look at how it is today, that majority of the radiation oncologists today in cervical cancer, if not contraindicated, want to use IMRT, and it has shown that patient tolerate it better, and that is how they do it. But here around 50% did not use IMRT but the traditional 3D planning. This is where it is. What I'm speaking of is who received which protocol. If you look at IMRT was in 40, majority were the conformal 3D. If you look at how the people completed the 6 cycles of neoadjuvant chemotherapy, around 80%, 85% completed neoadjuvant. So it is doable. Neoadjuvant chemotherapy is doable, and you rarely would find a patient who would not complete the chemotherapy. The most important was the median interval between induction chemo to the radiotherapy, and it was only 7 days. That's something that, again, after induction 6 doses, you can do a concurrent chemoradiotherapy. And look at how many of the patients completed 5 cycles of concurrent chemotherapy with cisplatin. 80% could complete 80% 5 cycles, and 90% could complete 4 cycles. So basically, to tell you, this protocol is doable in a setting like India, and we can do this protocol, and majority, around 85 to 90%, will complete the concurrent chemoradiotherapy following the induction chemotherapy. And look at the PFS. The graph starts separating very early, and if you look at the PFS curves, it is statistically in favor of the neoadjuvant induction chemotherapy followed by concurrent chemoradiotherapy, and that is something all of us have to remember very, very clearly. And look at and it is statistically significant. That is something which I wanted to highlight, and the hazards was 0.65. So you have 35% benefit on the terms of PFS at around 5 years and beyond, which is the endpoint which we saw. And if you look at the 5 years PFS, it is again exceeding what we normally saw. We remember what I told you, 60% is the PFS what we got in the landmark trials, which has been there for last 3 decades. Now it is going up to 73%. The number 2 which is happening is the 3 years PFS in the concurrent chemoradiotherapy arm is 72. It is dropping to 64, so there's an 8% drop in 2 years. But in the induction chemotherapy followed by CTRT, there's only a 2% drop. So something is happening with the neoadjuvant therapy that is letting the PFS sustain its 3 years value. So what I'm telling you is, you have breached and gone beyond the landmark of 60% 5 years PFS. You also are getting the relapses which are happening lesser. These are two things that are happening with the neoadjuvant. And look at the OS, which is the co-primary endpoint. And if you look at the OS, the hazard is 0.61, so that is a 39% benefit on the terms of survival. And the OS at 5 years is around 80%. The delta difference in OS is around 8%. So this is something that is definitely we should consider in our tumor boards in the right patient category, which has been done. Will a 6-weekly Paclitaxel carbo be added so that we can get a better PFS at 5 years and also OS? Now coming to recurrences, as expected, you had lesser distant recurrences in the neoadjuvant induction chemotherapy, and the locoregional relapses were nearly the similar thing. So now let's come down. There have been previous neoadjuvant trials. What worked for interlace? What did not work for other trials? Where the interlace investigators sharp and they did that homework very nicely. What was the dose that was there? What was the schedule? What is the patient profile? That's something which I wanted to tell. And this is a very beautifully drafted trial. If you look at it, the previous neoadjuvant trial which was done was with gemcitabine and cisplatin, followed by chemoradiotherapy versus chemoradiation. And what this trial showed, that if you added induction chemotherapy, actually you had inferior outcomes. This is there in the JCO publication few years, 1 decade back. But this is one of the landmark meta-analysis which people should remember, and this is why I tell interlace investigators were very sharp. Just look at it, what happened. If you look at this analysis and look at the interaction p-value, there were two things that were significant. The p-value interaction, if you look at it, this is where it is. And two things that were significant is, if you give a schedule which is less than 14 days, means if you give something which is within 14 days, let's say weekly schedule, that is better than giving a 3-weekly schedule. Number two, if you give a cisplatin dose which is intense and more than 25 milligram per meter square per week, you could find advantage in the induction chemotherapy. So two things, you have to give a chemotherapy much more frequently, less than 14 days, and you have to maintain your cisplatin dose intensity at around the 25 milligram per meter square or more. So what this trial interlace did was, it did both the things. It had a schedule of intensity of chemotherapy, cisplatin beyond 25 per meter square, and it gave a weekly chemotherapy. That is probably interlace is working. Number two, can we do an adjuvant? Can we do a chemoradiotherapy and then do adjuvant? If you look at the Outback trial, the Outback trial is a publication again published last year. This was adjuvant chemotherapy following chemoradiotherapy as primary treatment for locally advanced cervical cancer versus chemoradiotherapy alone. Again, paclitaxel, taxane, carboplatin were used. What happened in this is very, very striking. And if you look at to this part of it, just look, around 450 patients were assigned to both arms. Only 350 completed chemoradiotherapy. So 100 could not complete. So 1/3 could not, 25% could not complete. Of those who completed chemoradiotherapy, again 92 did not start adjuvant chemotherapy because of toxicity persisting. So what we're happening is, we're losing around 30% of patients in the adjuvant arm, which is not able to take the planned adjuvant chemotherapy. So the take home is, this trial was negative for the adjuvant. So if you look at the Outback, what happened is, this trials is negative in terms of PFS and OS. So this is again something very, very significant. Now, what more has happened in the concurrent chemoradiotherapy arm is the Keynote A80. This is again a beautiful trial, again a positive trial. What it did was, it took 1B2. Mind you, 1B1 is out. It took 1B2 to 2B, which were node positive. So here you had also 1B, 2 and 2B which had to be node positive, and or stage 3 and 4A. So the patient selection is little different from the trial which we showed in the interlist trial. Here what happened was you did add pembrolizumab to the cisplatin what you are giving versus placebo plus concurrent cisplatin, and then you did your chemoradiotherapy and did pembrolizumab after the completion of chemoradiotherapy for 15 cycles. So basically, you are adding pembrolizumab to the induction of chemotherapy, to the concurrent chemoradiotherapy, and then following up with the maintenance pembrolizumab versus you're comparing with the standard chemoradiotherapy, what is normally done. I have told you the selection criteria is little different. The 1B, 2 and 2B need to be node positive, and the 3 or 4A could be node negative, and this is something that is different from interlace. The second point that is different is the positive lymph nodes, either pelvic or para-aortic, were there in around 82% of cases. Only 17% of the patient did not have lymph node enlargement compared to in that interlace around 50% or 40% did not have lymph node enlargement. So mind you, there is a lot more bulkier disease in the keynote 818. The patients who undertook EBRT, the IMRT was around in 90% compared to 40% which took IMRT in the interlace. So these are the major differences, and the second difference is the more than one PD-L1 positive was there in around 95%, 94% of patients. So majorly, all of these patients were PD-L1 positive. So what happened is, the point is it's a very short follow-up. The follow-up is around, median follow-up is around 18 months. The follow-up is very short compared to interlace, which was around 60 months. So there is a difference in the follow-up. But with the limited follow-up, the PFS is significantly in favor of the pembrolizumab arm. And if you look at it, both the PFS has not reached the median in both the arms, but still the graphs have started to separate from around 3 months of time, and you see the separation continuing. So that is something we need to know, and it benefited all subgroup of patients. And if you look at the OS, it is immature. It's a very short follow-up. We don't expect it to mature, but at that limited OS, it looks like it is looking better. The curves are starting to separate, but we should not be looking at the OS at this point. It's immature. Now next, what happens next is the duration of response. As usual with immunotherapy, if you have a response, the duration is much better. And the safety summary, if you look at it, it does not look like it is much different from what is happening. The patient quality of the reports, QOL data is not looking bad if you add concurrent pembrolizumab to what has happened already to the concurrent chemoradiotherapy, what we do with cisplatin and radiotherapy. So is it that we should add starting pembrolizumab? To tell you that FDA has approved pembrolizumab in concurrent chemoradiotherapy at least in stage 3 and 4A and in the PD-L1 positive. So that is done. So now what we should do is, so what we should do is, we are looking at Kala, which is again a trial not using pembro but using durvalumab. Mind you, pembrolizumab is a PD-1, Durva is a PD-L1 blocker. The point which I want to make you is this is again a robust data set, and the data set is approximately 1,000 patients. And if you look at it, cut the whole thing short, the big thing short, the durvalumab arm plus chemoradiotherapy versus placebo plus chemoradiotherapy, it looked that durvalumab is not doing well as compared to pembrolizumab, which is doing well. So the point comes is, we have one immunotherapy which is working, the same patient group, and one which is not working. Can we mute Dr. C? Dr. Yeah, please. Yeah. So why did one succeed and why did one fail? Because there is one immune checkpoint which is working, one which is not. Very important. Look into the further details of it. The inclusion criteria of keynote A18, which is the pembro data, needed at least 2 per nodes to be positive and diameter of the node to be short axis to be beyond 1.5 centimeter. While Kala, which was durvalumab, which is a negative, had only 1 node positive and the size should be 1 centimeter. The point is, pembrolizumab trial had more bulkier disease. The trial for the immunotherapy for durvalumab had lesser bulkier disease. The point number 2, if you look at the Durva and the post-hoc analysis which happened with Durva, if the PDL was more than 20%, the durvalumab did work and the benefit was there. So the amount of positivity for a PDL1 positivity had to be more for Durva to work, and Durva had lesser bulkier disease. That's why the events are happening lesser. Might be in the longer follow-up, the durvalumab chemotherapy, concurrent chemotherapy Durva might be positive, but at this point, it's a negative trial, and pembrolizumab is a positive trial. So this is the take-home, that we have 2 new additions now. Either you can go for an induction chemotherapy weekly, or you can go for a induction, we can go for a concurrent with pembro and do it 15 cycles of pembro after the concurrent chemoradiotherapy is there. But mind you, the concurrent chemoradiotherapy with pembrolizumab is not approved in India as such. It is approved by FDA as of now. So now what in a patient with a deep pockets, what should we do? Should we just now still go to concurrent chemoradiotherapy? Or should we go for a neoadjuvant approach? Or should we go for an immune checkpoint with concurrent chemoradiotherapy followed by immune checkpoint maintenance? Patients with non-deep pockets, I think neoadjuvant chemotherapy interlace deals it. But someone who has deep pockets, should I add my concurrent pembrolizumab? I think data is there for us. The data is very short follow-up. That's the only thing going against it. Otherwise, patients with cervix can neoadjuvant who are eligible for concurrent chemoradiotherapy, not eligible for surgery. My take is, will neoadjuvant chemotherapy be an integral part of the treatment paradigm in CS cervix considered inoperable before initiating concurrent chemoradiotherapy? My simple take is, concurrent chemoradiotherapy appears coming second to both approaches. So in 2024, in the right patient group, I just cannot offer the patient just concurrent chemoradiotherapy. We need to offer at least something. It could be neoadjuvant, it could be concurrent, that is your choice. But the inclusion criteria is important. What I normally feel is, if there's more bulkier disease, more lymph nodes positive, I might go for pembrolizumab if the patient can afford it, especially in stage 3 and 4. But if someone who cannot afford, or there is lesser bulkier disease compared to what the keynote was, I will go for the weekly Paclitaxel carbo. So this is what it is for me. Now I go to the metastatic CS cervix. GOG 204 did tell us that paclitaxel cisplatin is non-inferior to other regimens with cisplatin, venirabin, cisplatin, gemcitabine, cisplatin, topotecan. So we shifted way back for all patients with metastatic CS cervix recurrent to cisplatin paclitaxel. The Japanese trial JCOG did tell us that paclitaxel with carboplatin compared to paclitaxel with cisplatin, if you look at it, the simple thing is paclicarbo is non-inferior to paclicisplatin. And because carboplatin is better tolerated, we now have shifted to paclicarbo. Point number 2. Point number 3, if you look at it, is where does the biological of bevacizumab come in? It comes with the GOG 240. It's a trial which was well designed. It had 2 arms. One was paclitaxel with cisplatin, which was the standard of care. One was pacli, and bevacizumab. Other was a non-cisplatin regimen, that was pacli and topotecan, and a pacli topotecan with bevacizumab. So basically, if you look at it, there were 2 regimens, one pacli-cis and one pacli topotecan. Both regimens also had 2 arms with bevacizumab 15 mg per kg. What this trial showed you, simple thing is, the non-platinum and the platinum appeared to do better. So topotecan paclitaxel had more toxicity, was inferior to cisplatin paclitaxel. The second point that comes again is, if someone has not received cisplatin in the concurrent chemoradiotherapy, then the cisplatin paclitaxel did much better. The point number 3 is, if someone added bevacizumab to chemotherapy, it was better than chemotherapy alone. So now we have shifted from paclicisplatin to paclicarbo. And with GOG 240, we shifted in the right patient who did not have fistula, did not have massive bleeding, to Paclitaxel carbo with Ben. So this is how the evolution has happened. So now, should we be adding immunotherapy to this regimen? We have two trials. I'll go to two trials very, very quickly. One was Atezo, added to platinum-based chemotherapy plus Bev versus bevacizumab plus chemotherapy platinum doublet. Very simple. These patients should not have received anything for the metastatic, and these patients should be eligible for bevacizumab. Mind you, this trial, if you look at it, when I'll come to Pembro, you'll know why I'm stressing on that. Bevacizumab was mandatory for this trial. And this is something people would remember, that you use Atezo only for those patients who are eligible for bevacizumab. And this trial is called BEAT-CC. And this trial was randomized 1:1, 410 patients. What it did show is, if you look at it, the most of the patient, de novo metastasis was in 23% of patients, and most of the patient had received some form of treatment in concurrent chemoradiotherapy before and then had relapsed. The PFS, which was a co-primary endpoint for the BEAT-CC, was superior to Atezo versus the chemotherapy and bevacizumab. So addition of immune checkpoint did benefit, and if you look at it, the endpoints of benefit of PFS was there at 12 months, 24 months, and 36 months. So if you look at 36 months, there was more than double the patients in the Atezo arm which were surviving without relapse. Now come down to the OS. Again, if you look at it, patients had significant OS difference, and that OS curve is separating. And if you look at the 36 months, the OS curve is nearly, not exactly double, but little bit of 1.8 times what it was with the Paclitaxel, cisplatin, and the bevacizumab. So what this tell you is that in the bevacizumab eligible patient in a stage 4 recurrent disease, you should be adding patients who are having this disease subtype, if they can afford an immune checkpoint to a Paclitaxel, platinum, and bevacizumab. It benefited across every subgroup. There's no subgroup which did not benefit. The response rates were superior. The delta of response rate for addition of Atezo was 12%. And look at the duration response. And if you look at the median duration, 8 months versus 13.5 months. Again, it was that when immune checkpoint performed well, they did have the benefit going on. So BEAT-CC, if you look at it, the PFS, the time to the next treatment, the PFS2 and OS all look very, very robust and were in technically benefited the immune checkpoint arm. The safety summary is nearly what we know. There's no extra thing to safety, but this has to be taken in context with Keynote 826. Keynote 826, if you look at it, was similar. The only thing was bevacizumab was not mandatory. So if it was not mandatory, 2/3 of patients, 66% of patients actually received bevacizumab. 25 to 30% of patients did not receive bevacizumab in the Keynote 826, which is again a positive trial. Keynote 826 told you in the updated analysis that if it is PD-L1 positive, patients of CS cervix benefited by addition of pembrolizumab to the chemotherapy skeleton, and the benefit was much more if bevacizumab was added. This is something people would remember. When 826 told you that if Bev is added, you had more benefit, and if you had PD-L1 negative, the immune checkpoint benefit is not there. So mind you, pembrolizumab should not be used because the approval is for PD-L1 positive only. And if someone has the time to go into the details which are published, in PD-L1 negative, the benefit is not there with pembrolizumab. So this is something which is there, and the response rate and duration of response is also benefiting the immune checkpoint only for PD-L1 positive and beyond. And there was also a subgroup analysis for patients for the bevacizumab subgroup. Basically, it told you two things. I'll go quickly. That patients who were PD-L1 positive with bevacizumab, the benefit was much more than patients who did not have bevacizumab. And it was that the patients for the survival was also more for the bevacizumab versus without bevacizumab. But if you did not use bevacizumab also and use pembrolizumab plus paclitaxel and as platinum, the OS curves looks also very good without bevacizumab. So mind you, if you use bevacizumab to immune checkpoint and chemotherapy, the benefit expands. The DFS benefit is not there, but the OS benefit is still there if you use immune checkpoint and chemo without bevacizumab. So now going on, I just skip this. It's the same thing which is told. I'm not going to anything on that. So what is my take home? Is the Bev issue being solved? For me, if there is no contraindication to bevacizumab, I will use immune checkpoint and I expect better response. I expect better duration of response. I expect better PFS. I expect better OS. But someone who is not eligible for bevacizumab, I will use pembrolizumab if the PD-L1 is positive. I would not use atezolizumab because that trial did not have anything and did not have patients who were not received bevacizumab, while 826 keynote with pembrolizumab had patients who were 33% of patients did not use bevacizumab, so I will use pembro provided the PD-L1 is negative. In the PD-L1 negative subset, I will not use pembro. I'll be little skeptical in using atezo even. So for me, for cervix, I need to do the PD-L1. It has to be positive. The CPS has to be more than equal to 1. Then only I'll use it. So switching gears to ovarian cancer, one trial has made a lot of difference, and that is mirvetuximab soravtansine versus investigator choice of chemotherapy in folate receptor alpha high platinum refractory ovarian cancer. So this is a very simple trial. This patient had to be platinum refractory, means the patient had to relapse from the last therapy with platinum within 6 months. Point number 1. Point number 2, they should have a very high folate receptor alpha, which had to be very high, and that definition is by IHC they should be PS2 and they should have been seen in more than 75% of cells. If you look at the previous trials, they also used more than 25%, but they found that in more than 75% patients, if it was positive for the folate receptor alpha in the IHC 2+, the benefit was much more. So that's why Mirasol, which is a phase 3 randomized trial, used this criteria of IHC 2+ in more than 75% of the cancer cells. Very important. It could be 1 to 3 prior lines. Prior bevacizumab was allowed. You could have patients who could use prior bevacizumab. PARP inhibitor was allowed. So you could use patients who had failed PARP inhibitors. So that is something people have to remember. And platinum refractory were excluded, means patient who had relapsed within 3 months. Because they were prognostically very, very poor, that's why they were excluded, but 3 to 6 months were allowed. These patients were randomized to mirvetuximab, which is a ADC, 6 milligram per kg, every 3 weeks versus investigator choice of chemotherapy could be paclitaxel versus PLD, that is liposomal doxorubicin, pegylated or topotecan. And PFS was the primary endpoint, OS was the secondary endpoint apart from response rate. What it told you in the 244-50 patient trial, coming to the report, the PFS was superior for the mirvetuximab versus chemotherapy, which is what we are following till now. And look at the response rate, it was technically and statistically superior. And look at the response rate, was 42% versus 16%. Again, something we have to remember. The OS was also superior and the hazards was 0.67, so 33% benefit by adding mirvetuximab versus what we have been practicing today. And look at the curves. They start separating early and the separation goes on. And look at the outcomes with prior bevacizumab. If it is bevacizumab naive or pre-treated, the benefit was there. That's something we need to remember. Toxicity, there were little more toxicity which were in favor, which were nearly the toxicity, all grades were similar, but you could have little different toxicity like diarrhea and others which you have to take care, and this we need to remember. But this has to be taken in context with Aurelia trial. Aurelia trial is one trial which is chemotherapy versus bevacizumab plus chemotherapy. This is a very old trial. Why I'm putting this trial in context, I'll tell you in a minute. This was again in the platinum resistant ovarian cancer. And this patient with chemotherapy could be switched over to optional bevacizumab monotherapy, or the Bev plus chemotherapy continued with bevacizumab till there was a toxicity. And this is a subgroup analysis of the paclitaxel segment. This used GEM, this used topotecan, this used liposomal doxorubicin. I'm talking of the paclitaxel group of patients. If you look at it, pacli alone versus Bev plus pacli, and look at the median OS, is 22.4 months. So what is this telling me of sequencing? I'll tell in a minute. The inclusion criteria, I can tell you at this point, mirvetuximab is a costly drug, not available, you have to import it. But the most important is the folate receptor alpha, which is approved on the Ventana platform, is unavailable in India. You have to send it to outside to get this done, and this has to be positive for 2+ in 75% of the patients. That is why it looks little unattractive. Otherwise, scientifically, the data is very robust. For me, I will use all my patients with platinum refractory a weekly pacli with bevacizumab, and then offer them mirvetuximab if they can afford it in the right patient group. That is something we need to remember. Why? Because a weekly pacli and a bevacizumab gives you a good 2 years of OS. And if you add mirvetuximab to that, after the failure of bevacizumab and weekly pacli, it looks further better. And mirvetuximab allowed prior bevacizumab. That's also something we need to remember. So this is how I'll sequence. Again, last point of my talk, weekly dense dose. Should we use a weekly pacli carbo in ovary, or should we use a 3 weekly? This is a ICON 8 trial, and this is a subsection of ICON 8, that is ICON 8B. They used compared arm B1 versus arm B3. So arm B1 is nothing but a 3 weekly pacli carbo plus Bev, and arm B3 is nothing but a weekly pacli carbo plus Bev. To cut the thing short, the weekly chemotherapy with pacli carbo and Bev looked superior to 3 weekly pacli carbo and Bev. This is something that is coming out of it, irrespective of the surgical approach. Whether you do an immediate cytoreduction or in between the cycle, the OS looks superior for the weekly, and the OS difference, the delta is around 10 months. So what it tells you that if you're using a Bev, you should probably use a weekly pacli carbo, the things will be better. But if you're using Bev and you want to operate in between, you do not use Bev for the 3rd cycle and the 4th cycle, and the surgery happens between the 3rd and 4th. That's something we need to remember. The Bev has to be stopped so that the healing process can happen. A quick thing on the HIPEC, and I will again ask my surgeons to tell me this, because a lot of them do HIPEC and all of them feel not happy when we as medical oncologists do not approve of it. There's an updated analysis which was presented in 2023, the final analysis for the OVPEC-1. This trial is criticized for many reasons, but with all the criticism, it does tell you that with interval cytoreduction, HIPEC has shown and sustained its OS benefit and the PFS benefit. Number 1. Number 2, only this one subgroup is something which people remember HIPEC may not be done and we can avoid it, is the BRCA1 subset. If this subset is not benefiting for HIPEC, both in the PFS terms and both in the OS terms. And this is not a one trial is showing you, there are trials and trials just showing you in the germline or somatic mutation for BRCA, HIPEC probably does not help because the other things are probably doing better. And the second point, post progression, if you look at it, the surgery and the surgery plus HIPEC, the patient received equal number of patients received post-treatment, post-progression treatment. So basically, if you want to do HIPEC, you can do it after interval cytoreduction as per the OVPEC-1, but there are people who still feel that we need further robust data before we do HIPEC. There is one more trial which is CHIFO trial, which was presented in 2023, and this is a HIPEC in platinum-sensitive relapsed epithelial ovarian cancer. This trial was positive for OS. The delta was around 10 months. The point why it is not accepted is, if you look at it, the PFS, the peritoneal PFS, where the benefit absolute was only less than a month. Although it benefited in OS, but the PFS and the peritoneal PFS, the benefit was only less than a month. So people feel this is one trial which is not very robust. The numbers, although maybe 400 plus, we need something more as a trial to follow it up to make HIPEC even acceptable in platinum sensitive relapsed ovarian cancer. So what is my take home in HIPEC? For platinum sensitive relapse, I'll still wait. For the patient with upfront, I will in OVPEC 1, I will probably after I do neoadjuvant. Then if the patient achieves the optimal cytoreduction and if the OVPEC 1 criteria is fulfilled, explaining the patient the toxicity of HIPEC and the cost, this methodology can be tried, but there are even gynaec oncosurgeons who still feel skeptical about HIPEC. But for relapsed patient, I will still not offer it. I will be very skeptical because CIFOR is one of the early trials and the data for the PFS is very, very poor. For platinum insensitive or refractory, I will never offer HIPEC. That is where I stop. And Dr. Bhavna, we can have a discussion. I touched cervix and ovarian cancer. I tried to cover little bit of surgical parts because I felt this trial needs to be covered when we are completing the gynaec oncology. Thank you. If someone has done a 15-month surgery and then there's adjuvant Paclitaxel and the disease-free survival, okay, 15 months of follow-up. So I expect it's a platinum sensitive. For such patient, what I do for a clear cell is two things. I definitely send for a NGS. That's what I do. I do re-challenge the patient with a BEV and a Pacli as I told you. That's two things which I do and wait for the NGS and act on the NGS reports. And you will be surprised to get good amount of mutations and which you can target later on. So that is how I do my practice. This is Madam's question, Bhavna Madam. What is your take on PIPAC?
Yeah, Dr. Moy is already there. She can directly ask the question to you. Moben. Well, she wants to ask the question on HIPEC for advanced peritoneal disease in case of CO.
I really don't advocate that. I think surgeons can really tell if they want to do it.
Yeah, we have to take one more lecture for HIPEC also.
I think HIPEC and PIPAC can be taken by a surgeon, and I think that requires someone who has a balanced approach. Because some people are so pro HIPEC, they forget that there is a toxicity to that also.
Okay.
So that is something which I think we are done with the questions. I think last question. As a pathologist, I wanted to know what is the role on the histotype in taking a decision for subgroup analysis. For cervical cancer, two things. The adenocarcinomas do not do as well as squamous cell. That's point number one. Point number two, the PD-L1 positivity is lower in adeno than in squam. So this is my take on it, that if it's a squamous cell, I'm much more convinced the patient is likely to do well. And the chances of PD-L1 positivity is higher in a squamous cell. For the ovarian, I think it is all about histology. If it's epithelial versus non-epithelial, totally a pathologist domain. If it's epithelial, I look at mucinous versus serous. And if it's a mucinous, even I sometimes do not do BRCA also, because you would unlikely to find a BRCA in a mucinous. So this is how I approach. And the patients, how mucinous does is little bad than how a serous does. And in mucinous also, if there is nothing as ovarian mass, I'm little skeptical. I also look at the appendix part. I always do a CA when I do a mucinous variety, apart from the C125. So this is some things which I feel I looked at it. The last question is carcinosarcoma relapse. What do I do? How I do, I will tell you. I may be wrong. You may correct me. I do, there is no standard approach. I have tried even adriamycin-based therapy with ifosfamide. It has worked in some patients, but they normally, the responses are very short-lived. I've used even taxanes. I've used even patients with carcinosarcoma. My main practice has been adria and ifosfamide-based. That's where I really stop with the carcinosarcomas. Taxanes is my second line to go to in carcinosarcomas. If something more can be added across to carcinosarcomas, you really can tell me.
No, sir. I also know that carcinosarcoma are actually the bad disease, refractory disease with the chemotherapy. So I also use this ifosfamide-based regimen apart from this paclitaxel and carboplatin. But before closing, sir, my last question from my side that what will be your opinion on low dose nivolumab? Though it's the data is only for the 20 patients, low dose nivolumab in recurrent metastatic CA cervix.
I'll be little clear on it, how I think it is. I'm very clear that you should only use low dose when people cannot afford it and you have taken a right consent for it. Point is, the medical oncology fraternity is jumping at low dose and ultra low dose for every patient. Be clear that even in the one approval which we have got from Tata Memorial for head and neck cancer also, I take a consent that the patient cannot and is not ready for a normal dose nivolumab or a pembrolizumab. If you look at the Tata Memorial paper, they have told that still they believe that the normal dose immune checkpoint are the standard of care. They do not know how this ultra low dose nivolumab will do. So you can do it, and I can tell you ovarian cancer is not a very hot tumor. You may try it in renal cancer, in melanoma, you might get response. I'll be little skeptical. Immune checkpoint are still not approved in ovarian cancer as such. I will be very, very skeptical. I will only do it if the patient has a MSI high. Then I'm very happy to do it. Otherwise, I do not think really of a low dose nivolumab in ovarian cancer. I will wait for further data. If someone has to do it, I will take a proper consent, save the doctor from legal hassles later on. Because no patient is going to stand by you, patient is going to bite at you once they progress. So please be very clear on that.
There's one question from audience is Galaxy M221 has asked that any specific reason why BRCA1 wild type patient don't?
There are some hypotheses. That could be because of also the BRCA agents, but I'm not very sure. I will not lie on a scientific symposium. I have to get back, but I have read some hypothesis that is there. All of us can go back and probably I can share to you, Bhavna madam, on the WhatsApp, and then we can get back, or on the temporary WhatsApp group, I can share it by tomorrow.
Okay.
I do not want to tell something which I'm not very sure. But there are some hypotheses. I know that I've read it, but I don't remember it offhand.
I just want to ask one question. After looking to Interlace trial, have you started practicing induction chemotherapy followed by CT/RT in CA cervix patient? What you will start in 2024?
Yeah, I started. Okay. It is already there. I do not want to deprive a patient at 12% benefit on PFS and an OS benefit of around 8%. It is too much, madam, for not to give them an option.
Just a last question that I'm a surgical oncologist, not this whole thing is very, I just keep updated with this. But how many of your patient completes olaparib for complete 1 year or more than that?
I can tell you with the cost getting lower, recently last month we can have more patients. But with the limited data set, I can tell you 20 to 30% of my patients have toxicities which prohibit me to probably continue. But the main thing is if you can get beyond the 4 months of the initial treatment, then it is very easy. So the 4 months initially, the initial 4 months is very tricky. The anemia, the fatigue, the gastritis, the GI toxicity really comes in. Take care of the 4 months. Call the patient little more easily. Counsel them before you start olaparib. That 2-4 months aapko problem hogi. Come back to me if there's anything. I think it will be much better.
So the rest of your 70% of the patient, they complete 1 year of treatment.
Yeah. Second point is that one more question. Patly Bev, I have told where I do it in ovary. I told Aurelia trial in a platinum refractory setting. So what I told is mirvetuximab had patients who were post bevacizumab. So how I will sequence it is I'll give weekly Patly and Bev. Once they're failed, and if folate receptor alpha is high, and I have that Ventana platform in India, and patient can afford mirvetuximab, I will give it post Patly and carbo, weekly Patly carbo, post weekly Patly and Bev, and in a right patient, I'll offer mirvetuximab after that because Patly, weekly and Bev is very cheap. Mirvetuximab at this point costs you 8 to 15 lakhs per cycle. It's too costly beyond most of our pocket. That is why I'll sequence it this way.
And what about bevacizumab being pre-surgery, with NSCT? How your surgeons, surgical oncologists or gynec comfortable because they have to operate and there are chances of spontaneous perforation. I also encountered with one of the patients, so I am just afraid of using it pre-operatively. So how your experience is with your surgeons?
How I do it, I don't ever offer bevacizumab pre-op.
No.
I don't do it. I don't give it.
So you give it post-operative with high-risk patients?
if they are inadequately debulked or stage 4, as it is in ICON and GOG.
Yes.
But if someone wants to practice, their patient should be receiving cycle 3 without BEV, then operate after a month or 6 weeks, and then post surgery, the cycle 4 which happens should be without BEV.
So like an alternative cycle you use?
No, ma'am.
Okay.
It is cycle 1, cycle 2 with BEV, cycle 3 without BEV, operate, and cycle 4 also without BEV, cycle 5 and cycle 6 with BEV, and continue BEV for the as per their criteria 15 months. That is how it should be.
So the surgery before one cycle and after one cycle you don't give bevacizumab? Before 2 cycles?
I don't practice BEV at all, neoadjuvant. But someone who wants to practice the ICON 8B, I told that in my talk that do not give BEV in cycle 3 and cycle 4, and operate between cycle 3 and cycle 4.
Okay. So
I hope that's pretty clear now.
Yeah, it is clear now. Disease progression of NACT Taxol with carboplatin in stage 3C ovary by Dr. Monroy.
The disease progression of NACT Taxol carboplatin stage 3C, basically it was inoperable, so someone gave it. And if it is progressing on platinum, and if it's a frank progression, the patient is going to do ultimately very likely to be a palliative end. Point number 1. Unlikely to be BRCA positive because of platinum insensitive from start. Very unlikely. So what I'll do normally, if the patient has deep pockets, I'll probably send for a mutation analysis, but I will start the patient on a single agent liposomal doxorubicin pegylite. That's how I practice. But very likely I'll tell my patient and the family, you are ultimately very likely to be never operable. You are most likely going to be a palliative setting.
One more thing, sir, can we try in these
plus minus BEV. You can do that BEV because now it becomes a near palliative end. Please, Akash, tell me.
Yes, sir. After a lipodox in refractory CA ovary, can we use that capecitabine and cyclophosphamide combination from that Indas, that COMCAPC? I have used 3 of my patient and got some kind of PFS benefit also, because the patient wanted only oral treatment and not the injectable ones.
I'll tell you one thing. If you look at the data set, and again on a scientific podium, I never have used this combination of the fixed. I am not still convinced of the fixed dose fundamentals. Very clearly. Number 2, I will use etoposide single agent. And look at the etoposide single agent that is approved. It is an acceptable thing, and you get a PFS of 4 months. It is not bad. Etoposide is cheaper also. So, will I use it? It's up to you, Akash. You may use it. I do not find robust data for me compelling to use a fixed dose thing. I will use a single agent etoposide, and I can tell you data set is that you will get responses in 20 to 30% of patients, and your PFS might be in 3 to 5 months of PFS.
Yes.
Just a last question by Dr. Sadika Gupta, and we'll close this session. What is the data on maintenance bevacizumab if they have not received adjuvant bevacizumab?
What is the data on maintenance bevacizumab maintenance?
Bevacizumab if the patient has not received adjuvant bevacizumab.
Okay. If the patient has not received concurrent bevacizumab, let's say induction. Yeah, that's what the question is.
Yes.
There are 2 things which I want to make it very clear now. People sometimes just use bevacizumab with pacli-carbo and then do not do maintenance. Please never do it. Look at that landmark trial of GOG. There are 3 arms. Pacli-carbo or pacli with platinum, pacli, platinum and 6 cycles of without maintenance, and then pacli, platinum, BEV with maintenance. If you use BEV, you have to use both in the induction, that is with chemo, and then give maintenance. That's how you should use BEV. You cannot start BEV after, except for in 2 settings, as I told you. If someone operated, like some gynaec oncosurgeon operated and there was a suboptimal cytoreduction. As per the GOG data and ICON, I can discuss BEV in that setting. That is the only setting I'll use BEV. Otherwise, if I'm not used BEV in the induction or the concurrent with chemo, I will not use BEV as such.
Okay, Dr. Sahu, thank you so much. And INSPECT is a medical oncology topic and our surgical oncology is as a coordinator. there were 82 participants were there in this Zoom meeting, and they were across the Asian countries because